my good friend, and all the participants tonight to today's topic by Professor Elsherbiny. My name is Dr. P.Y. Cho, and my co-moderator, Dr. Junior Tu. We both will moderate today's webinar. Professor Ahmed Elsherbiny is currently the consultant plastic surgery at the King Abdullah Specialized Children's Hospital, KASCH, Pediatric Plastic Surgery, Cleft and Craniofacial Surgery at the King Abdulaziz Medical City in NGHA, Riyadh, Saudi Arabia. As well, Professor Elsherbiny is the professor of PRS department, and he is the faculty of medicine at the Sohag University, Egypt. According to Professor Elsherbiny's training period, he received the fellowship training in UAB, Cleft and Craniofacial Center, Pediatric Plastic Surgery at the Children of Alabama, Birmingham, Alabama, USA, and learned from Professor John Grant. And he was also the clinic attachment in cleft lip and palate unit at Great Ormond Street Hospital at London, UK, by Professor Brian Summerland and Professor David Donowitz. So in Professor Elsherbiny, he also published numerous peer-reviewed papers and book chapters, and be invited for international speech in this field of craniofacial surgery. Today, we are so happy to have Professor Elsherbiny to be our presenter, and he will present the topic toward evidence-based velopharyngeal insufficiency VPI management and protocol. Also, we have invited two experienced and our good friend in ICC to be our panelists in the discussion session. The one is Professor Fayaz from Lahore, Pakistan. The other one is Professor Handa from Iwate Medical University, Japan. So we can wait to learn from Professor Elsherbiny. So Professor, please. Thank you.
Thank you, Dr. Cho, for the introduction. As you introduced me, I'm Ahmed Elsherbiny, Professor of Plastic Surgery in Chang University, and currently working in Riyadh, King Abdullah Children's Hospital. It's my great honor to join this and talk in this wonderful craniofacial webinar. Has been very consistent, maybe about 3 years. Great topics and great learning opportunities. It's not moving. Okay, it's moving?
Yes. No problem.
Okay, first I will talk quickly about the challenging of having an evidence-based management. And then we will go and the current literature, status of the literature. Then we will go for our current VPI procedures and the progression of our protocol based on our experience and research. First, I would like to acknowledge Dr. Samia Saeed, my head of department during my residency in Egypt, and my two cleft mentors, Dr. John Grant, during where I spent my fellowship in US, and Dr. Brian Summerland. It's longer relation with him, and for his leading in this physiological approach for VPI. I like this, the eyes of this statius. It's done from, they made it from crystals. It's 4,500 years age. First, the problem with VPI, it's a very complex problem because it's presented, it has a very wide presentation, and it has too much variables affecting the outcome. So if we go, also if we look to the literature, you will find most of the studies are case series. A few are cohort studies, and extremely rare to find randomized controlled trials. if you go with the kid in a primary repair, you'll find a lot of variables like initial cleft diagnosis and severity, primary cleft surgery and surgeon, certain syndromes. All this will affect not only the outcome of the primary repair, but also will affect the secondary outcome after VPI. The VPI rate reported after primary repair varies from 5% to 40%, big variation. And this is the story from the beginning. But when we go to the VPI, then the second procedure, things are getting more complex. In such problems, it's expected to have a higher number of patients in the studies, but there are two meta-analysis done in 2018 for all VPI procedure. They find the mean number of patients was only 42, and another 22 meta-analysis for the palatal procedure for VPI. The mean number of patients was 32. Syndromic cases only reported in 15% of the studies. Sometimes we have some variables which are affecting the outcome, which cannot difficult to be reported, like the muscle bulk, the palatal length, the scarring, the pharyngeal depth, and others. Regarding the outcome, the first outcome is the speech. If we look to the speech scores used in the studies, the majority of the papers reporting just perceptual speech outcome with but unvalidated scores, and only 6% found to have validated scores like the CAPS or the Pittsburgh score. Blind assessment and assessment for more than one therapist also are rare, and speech therapy are mostly not included in the details about the speech therapy and the duration and intensity. The other outcome is the secondary procedure, and this need a long follow-up to report it. And this meta-analysis, they found about 70% follow-up less than a year, 1 to 1.5 year, 18%, and 12% more than 1.5 year follow-up. The threshold and indication of secondary surgery also, if it's mentioned, it's not clear. The third outcome is the obstructive sleep apnea. We know the polysomnography is the gold standard for diagnosis, but it's expensive and time-consuming. So also the studies showed that about 50% of all VPI procedures and 20% of the palatal procedures are reported obstructive sleep apnea. Mostly are symptoms, and very few, like 13 and 5%, they reported real polysomnographic results. The patient satisfaction also another point which you mostly ignored in most of the publications. Now we'll talk about our techniques and protocol of VPI. As most people do, we start with the perceptual speech assessment, and we use the CAPS score. The nasal endoscopy, the most commonly used instrumental investigation by most center. We like to have a report on the gap size in millimeter and closure ratio, the palatal movement, and very importantly, the elevator direction. Like if we see here on the right side, we'll see the direction of the muscle fibers. And like in this case, it's vertical or oblique, and this common finding of the dorsal V deformity of the palate. In the oral side, in our protocol, it's important to look at the oral side to see if there is like average scarring, acceptable good scarring, more scarring sheet going to the soft palate, and complete sheet of scarring on the oral side of the palate. The lateral video fluoroscopy, it's nice in this complex problem. It's nice to have a different view and angle of the problem. This is King Ramses II. So lateral video fluoroscopy, we can confirm the gap size. We can importantly we can see the position of the elevator knee within the envelope of the soft palate. So to describe it, it's either anterior or posterior. The functional length from the posterior end of the hard palate to the elevator knee, and important also the level of closure when we are planning the pharyngoplasty. This is our protocol. We'll go one by one in it. First of all, we have to check if there is muscle movement of the palate or not. If it's not, these are mostly rare cases of neurological extreme syndrome, and mostly it's palliative palliative, we just try to improve it a little bit, but the outcome is not good. But here, if we go for we find a movement in the palate, then we have to check where is the levator knee and where is the velar direction. So the first step in the management is to take care of the muscle orientation, improve the palatal form and function. In this step, we have 3 procedures, all of them including a re-repair of the muscles. So we'll start by the first procedure as the palatal re-repair, and we'll go in details about how to select between these 3 procedures. The palatal re-repair by Samalad or secondary intraviral veroplasty. This procedure is aiming to improve the function of the palate through the complete dissection and retropositioning of the abnormal oriented muscle and put it in a more posterior horizontal functional direction. So the functional length is increased. And I always refer to this swing example. This from mechanics, we know that torque equals force times the elevator arm length. So if we push the seat down and with the same amount of force, we can get better torque and better excursion of the palate. This is the effect on the endoscopy, expected effect of the endoscopy of the re-repair. The procedure of intraviral veroplasty was described a long time ago by important names like Roding, Braithwaite, Otto Kreens, the first who named it the intraviral veroplasty, Peter Randall, until cord cutting, and then in Summerlad in 2003, they prescribed it a much detailed anatomy with a microscope. Because before of this, it was confusing term, and the result was always inconsistent. How much you dissect, and everyone thinks this is the intraviral veroplasty. So this is a great contribution with Mr. Samanad to see this much details anatomy. It's used in the secondary repair for VPI, first reported by Dillon and Edgerton in 69 and 71, and then by Samanad with a microscope in 94. To show the anatomy, it's better to be seen in the primary cases. Here is the case after we elevating the oral mucosa, and this is the midline repair of the nasal mucosa with the muscle, and this is the posterior edge of the hard palate of this side. The tensor tendon, it's shown in the anterior lateral part of this hemipalate, and then the fibers of the palatopharyngeus. Where is the elevator? It should be in the nasal side of this muscle group. So, and when we try to dissect the muscles from the nasal side, we would find this tethering of the tensor, limiting the retropositioning of the muscle. And then completing the release of the muscle bundle between the nasal layer and the remaining part of the tensor until we completely release the muscle as shown here in a strictly horizontal direction. And here is the view showing the levator going up toward the base of the brain, the levator tunnel, as Mr. Samalad named it, and overlying some fibers with palatopharyngeus, also remaining here some vertical fibers with palatopharyngeus. And here's the midline of the nasal mucosa. This is a nice paper by Dr. Grant. He described the extent of he classified the extent of the intraviral veroplasty from where if you were gonna release it from the nasal mucosa, oral mucosa, parietal shelf, lateral or tensor tendon. And they used to do a less aggressive one, and they name it 2B. And then they change it to type 3, the radical one, as Samalad way. And they find significant difference between 2B and 3. And I think the conclusion is that the muscle dissection, it should be either done completely or not complete, or it's better not to be even touched, not to reduce its scarring while you are not getting it completely transverse. And I was just show in the video, you need to release it far laterally, go to the tensor to completely release the muscle. In the secondary cases, this is one of the examples of the John Grant's case. It's the same technique, but sometimes it's in like a case like this, have fibrosis that make it it's a little bit more difficult. And it's like example of you are digging for an unearthing for a treasure. So you have to be very careful not to not to injure not to make damage. And the same to the muscle, to the precious treasure, or it's the muscle, and we find immediate intraoperative lengthening from putting the muscle in this retropositioned location. Another nice trick I learned from Summer Lad is after we dissecting the muscle, we take a posteriorly based it's fibrous remaining muscles and some fat in the midline. We elevate it as a posteriorly based flap and suturing upon itself. So here here we see this bulge, and here is the muscle will be sutured to the other side above it. So in above picture here, I can name it. I like to name it palatal auto-augmentation. So we augment part above the muscle, so it aids in the closure of the bilopharyngeal valve. While in my fellowship, I reviewed the cases of Dr. Grant, and at the time he was using the re-repair in all as a first-line surgical procedure in all cases in anteriorly directed muscles regarding the VPI size. There was significant improvement in all speech parameters. Let's go here. But if we analyze the cohort of patients, we'll find that about 10% were not improved. Improvement was 90%, 66, about 2/3 of the cases improved, cured, 25 improved but didn't cure. So about 1/3 of the cases needed further surgery. And with follow-up of these cases, half of them, so about 1/6 of the cases will have, as we see later in the protocol, will have fat grafting to the palate, and 1/3 will have pharyngeal procedures. So by using the re-repair, only about 1/3 will have a secondary procedure, and 1/6 will have pharyngeal procedure. And some data about the factors affecting the outcome. The primary diagnosis found to have outcome affection, the higher VU classification, not only in the primary, as said, also in secondary. And interestingly, you find that about 57% of the study had already radical muscle dissection in the primary repair, which means that there is a significant part of the number of patients which the muscle will regain to its cleft position. But nice finding, interesting finding that if the intravira viroplasty done primarily, the final speech outcome after re-repair is significantly better. So this is what expected to be happen. If there is like scarring, it will tether the muscle and will contradict the growth and the growth of the location of the sling posteriorly. This could be happening in the re-repair. Another important point in the outcome is the time. This is very, very important. We find when we studied the cases, we find something interesting. And actually, this idea came from when we were when I was trying to follow up the cases. We see it at 6 months, 1 year. It's improving, but didn't cure. But then the patients appear for a couple of years, and she come for like a rhinoplasty or other procedure with completely normal speech. So I got able to look in about 45 cases, Dr. Grant. We find that there is a progressive course of improvement and can reach up to 3 or even 4 years sometimes. And the patients who are older than 6 years have a better or faster recovery than the younger kids. The theory behind it, it's mostly because edema will make fibrosis and hardening, scar remodeling, then softening, and then until we reach to the pliant palate, exactly like something like the post-burn scars, where we wait at least 1.5 years until we have a supple skin. A second procedure, it's called the PPAP, as Dr. Samalad named it. It's posterior pillar augmentation palatoplasty plus the intravira viroplasty. This is one of the oldest VPI procedure described. Actually, I find it that Passavant described it in 1865. And interestingly, this procedure was famous at that time and at the early 19th century. And they just united the posterior pillars, so so the palate looks longer. But this are very recently reintroduced by Summerlad, and he talked about it in the last Edinburgh meeting. And actually, I learned from him this technique like about 10 years. So we get able to get a number of cases in my fellowship with Dr. Grant. So this technique is just to build to lengthen the palate at the posterior end. But you know, now with the more knowledge of the sling, we can use this muscle to put it in this sling. Before they just united and they didn't change the position of the muscle. This is the technique. We recruit tissues from the posterior pillar. We repair the nasal side, complete the muscle, and actually this is mainly its interoperative indications. Like if we see that the muscle cannot be brought strictly transverse, we start to do this procedure. And then here we see in the lower picture, this is a location of the uvula, which show how much the palate was lengthened by this procedure. We find a lot of significant improvement in all the speech parameters. But interestingly, we find that the outcome was much less than the outcome of the re-repair. Maybe because the cohort of this study, of the patient population, is we selected more cases, more short palatal cases. And another interesting outcome, we found that cases presented with palatal fistula or previous VTI surgery so trend to associated worse outcome, which we understand that the more fibrosis, the less outcome of this procedure. And so if we take the example of the swing, if we built a pliable envelope posteriorly, still the anterior part, the fulcrum of movement, the hard port cephalad junction, still tessered by fibrosis. So this is not. So we concluded that palatal fibrosis and scarring is a limiting factor for this procedure, and better selected for a more pliable palate. The third procedure for this group is the vaccinator re-repair procedure. This is a very interesting procedure described first by Helen in 2004 in UK. They called it the vaccinator sandwich pushback flap. And then many reports came after, one by Summerlad in 2013 and Raphael Dinadei and others. The idea of it, as here the picture from the Hill publication, to cut between hard and soft palate, full thickness, and then use two flaps, one for the oral light, one for the nasal side. And it's primarily for lengthening. I published this paper 2020 as a combined procedure of vaccinator and re-repair with some modification than the original description. It's a very versatile procedure. It's very rare to have any necrosis because it's based on the buccal artery from the maxillary. It crosses the pterygopalatine raphe, runs between the muscle and the mucosa. So it's axial and very, very reliable. Here is the design. The donor site is like the original description. Below the duct of the tensor duct, about 1.5 centimeter width. We dissect under the muscle until we reach the pterygopalatine raphe around until we find the flap is reachable, and we face the buccal bed. What we modified in the cutting in the palate. This curvilinear incision, we ended by 2 back cuts, so it giving more lengthening, more retropositioning of the palate, and this lateral cut allow us to remove the midline scar and allow us to further lengthen the palate as a VY and bring the more thicker mucosa toward the midline. And so this is the defect after this closure. Before this, actually, we have to. And this is a incorporation of the intraveral vertebroplasty. We have to elevate the oral mucosa of the soft palate, and then we dissect the muscle as conventional. But here, it's importantly, we not separate it from the nasal mucosa. We suture it together. So, and then after this, the completion of the procedure, oral and nasal side are closed, and this is after completion of the vaccinator flaps. After 3 weeks, we divide the pedicle. Usually, the flap looks bulky at the beginning, and After a few months, it spread out due to pulling of the muscle on the flap. So that is the original vaccinator. We put a healthy tissue in the fulcrum, but the vaccinator repair also we increase further the muscle within the soft palate to increase more the functional length, and also significant improvement in speech parameters. And if we follow the cases, actually this cases was done in Egypt. The follow-up, we have some problem in the follow-up, so the follow-up was only about 6 months. But in this 6 months, we have about 25% didn't improve, 25% are cured, so 75% improved, and half of them improved but still didn't cure. And is expected with the theory or like the paper we just published that this will improve. And also, I think Raphael Dinoué also reported the significant improvement from 6 to 1 year. Even the scope is improving with time. And the patient was all, as we call them, the cripple, cleft cripple. They have severe scarring and severe patient population. And this is example of one of the case. This one is actually this case was done recently. It's a very, very wide cleft, but after the cleft, there is, as we see, the very short palate, a little bit, some scarring, but very short palate in a fistula. And this is the healthy tissue after about a year, with a significant improvement of the length of the palate. And here is the endoscopic finding, the dorsal deformity and moderate defect. And then after 1 year, a complete closure of the palate by a single procedure. And all endoscopic parameters improved: the convexity, the closure, the velar movement, lateral closure ratio. We also did in the study the lateral video fluoroscopy and lateral video fluoroscopic measurements. We did a lot of measurements. We find some interesting things that like the functional length increased 76%, and even more than the reported by Dr. Samalat without the muscle repair inside the procedure. Also, very interestingly, the contracting gap decreased 0.66% and the resting gap 0.18. And this is important for the obstructive sleep apnea, that the resting gap didn't decrease significantly, and still it's dynamic procedure. It's not affecting the resting airway. The palatal extensibility, which is the percent of the increase of the palatal length during contraction. Interestingly, we find that it's decreased in 22%, and we have some explanation about this. We think that there is ideal position of the muscle, and if you whatever you push more or you give, you will not lengthen or you will not push the muscle further. So there is ideal position. This is the target. We have to achieve it. We give like 1.5 centimeter flap width, and this is not translated into the same amount of gap reduction. And we concluded that this procedure is very importantly, the lengthening is a good effect, but we think that the more importantly than the lengthening is the breaking this scarring of tissue and to relieve the fulcrum of movement. So no cases of obstructive sleep apnea as regarding symptoms appeared, and this is the difference between the resting and gapping sides. Some endoscopic lateral video fluoroscopic cases, we see huge defects, and we see this picture in the lateral video fluoroscopy, the mega palates. This is preoperative, postoperative rest and contraction. There is some debate that say that okay, if you add a re-repair for a muscle repair for the vaccinator, is it gonna be time consuming? Actually, the re-repair is much easier in this procedure, because the most tedious part in the re-repair is dissecting the muscle from the nasal mucosa, and here you don't have to. We more application of the muscle, the defect is getting bigger, and it's going back with the mucosa, nasal mucosa. So we shifted now. It's not more toward the vaccinator re-repair, then re-repair in any doubt about the gap size, any doubt about the scarring of the palate. As if we do all re-repair at the beginning, as in the first paper, it's 1/3 of the cases will need further surgery. Palatal scarring could prevent achieve good results from the intraviveroplasty, and this is the common finding, at least in the Middle East patients. And as we just also in the second paper, that dynamic VPI procedure tend to have a time to establish the final outcome, and this is a very precious years for the kid that he's going through his early years of life in the school, and so combining surgery is better option. After maybe now approaching 80 cases of vaccinator, we started to find maybe until now we find 2 cases of re-repair after vaccinator. We find the adherence of the muscle so this is the vaccinator flap, and this is the muscle released from the tethering. It happened twice from this about 80 cases. And then also we do the same principle, the steroidally based flap in the midline, and then repairing the muscle over it to give augmentation of the palate, the auto augmentation. In this particular case, we find a big defect anterior to the muscle between the muscle and the vaccinator. So we added some bilateral fat grafting, bilateral fat flap to fill this area and prevent re-adhesion again. So this is the first part to improve the form and function of the palate. And this is the briefing of these 3 procedures. So if the envelope, the soft palate envelope is pliable, soft, gap is not mild to moderate, redo palatoplasty. If the palate is short and so we do, but the palate is pliable, we do posterior pillar augmentation, palatoplasty, redo palatoplasty. And this is a rare situation. Actually, most situation of shortening is due to scarring. This may be like an old submucous palate. There is no lengthening due to growth restriction. The muscle direction is not good. But most cases, more indication here, like in the scarring, short palate due to scarring, we do the vaccinator re-repair. And here is the example of the effect in the swing example. Then after we achieving this, the transverse muscle, and we optimize the palate, if there is a remaining gap, this is the step 2, closing the remaining gap after achieving a transverse velar slit. If there is a small gap, we go for fat grafting of the palate. If large, we go for Heinz pharyngoplasty. We don't do grafting to the pharynx, but to the palate. And this is a technique described by Dr. Grant in 2015. I don't know, is it safer than the pharyngoplasty? You know, all aware about the few reported cases of strokes and blindness in UK, but we don't know. Maybe it's away, the vascularity is not much connection like the pharynx, the vascularity is less. But it's the good thing in it, it's less obstructive than injecting in the pharynx. And so here we, under endoscopic guidance, intraoperatively, we inject. Like here, we injected the left side. And this is the effect in the endoscope. This is a picture of Dr. Grant doing the procedure. So we inject from lateral, so avoid the scar. And we have to compare the preoperative awake endoscopy to see where is the area, the target area, which we want to do. And after intraoperative endoscopy, we do the remaining. Sometimes cases need twice or 3 times injection. If the gap is large, we go for pharyngoplasty. And the version which we use, we follow the Dr. Samarlad in this point, that he used the high pharyngoplasty. Because if we achieve levator knee up to here, so we have to match just in front, just to coap this point of levator knee. So this need opening of the palate, splitting of the palate to reach this area. Sometimes we have problem with the adenoid need to be removed before, if it's at that level. The conventional Heinz, if we don't split the palate, if you just retract it, maybe the location will be lower and it's not fitting. Also orthocochlear sphincter, because it's used the posterior pillar, so also it will be much lower even. So the airway, if you look by the scope, maybe you find it closed, but actually the crooked pathway, it's not fitting this physiological approach. So if you go first to the first, if you do re-repair for all cases, at that time, the achievement was 1/6 of the cases had a pharyngeal flap, pharyngoplasty. So after incorporation of the vaccinator re-repair and other, now we're trying to collect data to, I think this number is decreasing much. So the need for the pharyngeal flap is much, much less. And actually in our practice become very rarely needed, but sure, we will always be needed. Obstructive sleep apnea after this procedure or of the pharyngeal procedure, we all know that it's variable from 20 to more than 90, according to the definition of the obstructive sleep apnea and the subjective, objective. But at least we know it is more obstructive than the palatal procedure. And very interesting information from Felicity Mihdal. They found that the pharyngoplasty after re-repair is significantly less obstructive than pharyngoplasty if done initially. So like in this example, initial pharyngoplasty, big defect to put a pharyngoplasty. But if you improve the palate and then put a small pharyngoplasty, expected to be less obstructive. This is King Tooth. By the way, he have an incomplete cleft palate shown by the CT image of his body. Last point is the fistula and the VPI. When we try to describe a technique for a palatal fistula with Dr. Grant, we find that about 80% of the cases when we do fistula repair after investigation, find it needed a re-repair of the muscle. And this could be due to the fibrosis and tethering of the muscle to regain it back to its cleft position. And a very recent study also find the higher incident and confirming this data that higher incident of VPI found in the cleft and the fistula of the soft palate. I will show 3 quick examples, maybe not like reverse example to confirm our procedure selection. Like this case is 26 years old, non-VPI cleft, has a deep pharynx and non-cleft. So here is the scope and rest and contraction. That you see the muscle is transverse, but it's a big defect. So this is a lateral video fluoroscopy. And actually, one of my colleagues, they did vaccinator. Let's see, here is the mega palate. So he did a vaccinator, not re-repair, but vaccinator re-repair in this procedure. And actually, there was no much improvement in the procedure. And interestingly, if we look at the oral examination after 1 year, the flap didn't spread like when it's indicated. And this could be confirming our theory that that when the muscle is already in its ideal position, there is nothing you can do to push it more, even if you put more tissue in front of it. So if in this particular case, if we put it in our protocol, it should receive, because it's a muscle movement, posterior muscle, you couldn't improve more. Large defects, we should go for pharyngoplasty instead of vaccinator. Another example, this is a moderate defect. If we look in the oral examination, there is some fibrosis going to the soft palate, but not all. The remaining part is soft, but the anterior part is fibrotic. If we this procedure, actually, I did re-repair. We're reluctant for vaccinator, but it's significant improvement, but still there is a defect. And here we can learn that if we have fibrosis, it's better to combine vaccinator re-repair. This could be like a gray case, but it's better to get more aggressive to finish the problem in one case, because this one will wait 1 year until we reach this result, and then maybe we will have some now fat grafting to the remaining defects. This is wasting time for the kid. But here in this example, this is the proper indication of re-repair. Mild to moderate defect, V deformity. If we look to the oral side, the palate is pliable, not much scarring. And if we look to the post-operatively complete closure after re-repair, and so a final point that it's nice to have a big inventory of procedures to deal with a wide variation of presentation. And we always like to start with this dynamic procedure, and we hope that we'll finish all by dynamic procedure, or we'll not need any pharyngeal procedure. We don't have to rush for the next VPI procedure, especially if it will be more obstructive procedure after this. And we have to close monitoring with improvement and continuous speech therapy. And like in this example, in borderline cases, we prefer to go for more aggressive choices to finish the problem in one procedure because of this time consuming and then significant number of need further procedure. But also we have to consider the family preferences. Sometimes they prefer a less aggressive procedure and willing to carry the risk for a higher possibility for a further procedure. And finally, I like to invite you all. We have a second Egyptian Conference of Cleft Lip and Palate in February 2024. And I would like to invite you all, and thank you very much for listening.
Thank you very much, Professor Elsherbiny, for your comprehensive talk on the VPI management protocol. And at this time, I'd like to invite our panelists for some comments. So first, I'd like to invite Professor Fayyad. Professor?
Thank you very much, Dr. Junior. Dr. Ahmed, very good presentation. It was an excellent talk. So my question would be, probably your preferred procedure in VPI management is to use the bilateral buccinator.
Again, please.
And your preferred procedure for VPI management is using bilateral buccinator. So
actually,
how many of the patients did not improve even after using bilateral buccinator flaps?
Actually, it's not the preferred. Yeah, it's preferred because we think that this procedure can get the best of the palate can do as regarding length, as regarding getting rid of scarring, as regarding putting the muscle in a good direction, as regarding recurrence of the muscle positioning anteriorly. But we still do a VPI re-repair because this is a longer procedure. Donor site is not really morbidity, but bigger, longer procedure, second procedure for cutting the pedicle. So there is a space still, sure, for re-repair if there is a palate, the gap is mild to moderate, if the soft palate is not much scarred. So we still do a lot of re-repair. Actually, we are trying to get a longer term follow-up after vaccinator. And still, I don't have accurate data because the publication was early. It was early study. And I'm not working currently there to follow these cases, but we are trying to collect data from. But actually, as we said, we need a really long-term data. We need at least 2 years to know what the percentage of using of after. But the impression, it's many cases are resolved after this procedure, or maybe some fat grafting. We did some fat grafting, or like a couple of cases had this re-repair after, and they improved, they resolved. But it's expected that I think we have to get out this information to know expected to be better than the only re-repair.
Okay, so what is your average time to do bilateral vaccinator in VPI management?
That's from 2 to you mean time of surgery, or?
Yeah, average time.
2 hours, 2.5 hours.
Okay. And so how many cases you need Heinz pharyngoplasty or articochia, and how many percentage of patients you go for a pharyngeal flap?
Okay, pharyngeal flap, we extremely rarely use it. We just use it, as we said, if there is the palate is not moving at all, and then we want to do something like palliative. If we see, so we go for the classic protocol. If there is some good lateral pharyngeal movement, we can put a midline flap. This is maybe the only indication. Regarding the pharyngoplasty rate, as we mentioned, when we're doing just only re-repair with Dr. Grant, the pharyngoplasty rate was 1/6 of the cases. Okay. After we incorporated the vaccinator re-repair and the PAP re-repair and these other options, these are getting much lower. So I very rarely now do pharyngoplasty, maybe once a year or something like this. We have to wait years to see exactly the numbers, but it significantly decreased now.
So when you use a pharyngeal flap, what is the average width of the pharyngeal flap taken from the posterior pharyngeal wall?
Yes, as I mentioned, pharyngeal flap, it's very, very selected extreme cases where there is no movement at the palate at all, nothing to do in the palate. So it's very few sporadic cases. We just try to see how much movement of the lateral pharyngeal wall, and also try to be more conservative because the patient already have mostly they are syndromic, they have neurological things. So we have to be conservative, maybe 50%. Not more, just to improve a little bit the speech, and that's it.
Okay, thank you very much.
Thank you very much, Dr. Fayez.
Thank you, Professor Fayad. Next, I'd like to invite Professor Honda. Professor Honda.
Hi, good evening. Thank you very much for your lecture.
Thank you.
In my understanding, you start as a dynamic procedure for the first line, and if it's not effective, you may go to the secondary procedure like the fat graft or pharyngoplasty. And my question is that what is the age for the intervention for the first line procedure, and how long to wait for the first line to second line procedures?
Usually the first procedure is around 4 years, where we can go have a good assessment by the endoscopy or lateral video fluoroscopy. In extreme cases, we sometimes, I remember one case I did it about 3.5 years before even assessment, because the case was very, very, very short palate, and the patient, just from crying, he's have severe nasalities. So in some extreme cases like this, we just go earlier. But most of the cases, we wait until we have a good assessment to select the procedure. After we learn now, we have to wait. We do a speech assessment every 6 months, and we try to see the curve if he's improving, because some of them they improve in 6 months completely. The curve is completely different between a patient and other. But we should have to be careful that the two consequent speech assessment, there is not much improvement. So some patient can have like 2 years, some patient have 3 years. So the speech input, speech team have to get input and they know now that they are aware that now we have to be more watchful to decide for the next procedure. Sometimes 2 years, 1.5, sometimes 3 years.
So maybe you at least 2 years you wait for the secondary procedures.
Yes, most of the cases, yeah.
Okay.
At least 1 year, and then we start to look in depth after 1.5 years, and then start to focus more.
Okay. And one more question, please. Do you have any idea for the Farrow type palatoplasty? You mentioned about the IBBP procedure of all of the cases, but how about the Farrow type palatoplasty?
Yeah, I don't have experience with Farrow, but I know that as you know, primary cleft palate repair, if you see the literature, there is Dr. Brian Samalad is getting 4.6, 5%. Also, there are some teams doing Farrow, like the CHOP, Children's Hospital Philadelphia. They have also, and Pittsburgh, they have good about the same average number of. We're not against it, but this is the way I learned it. So, but expect, the new version of Farrow, where you can see the same anatomy. If you see you are surely that the direction of the muscle is completely transverse. If you achieve this one by Farrow, it's okay. But if you do Farrow without putting in your mind this anatomy and putting in your mind that the sling is not really completely transverse, this is not the Farrow which we like. But the Farrow we like, they have the same knowledge of anatomy as the midline intervertebroplasty. So if you achieve this position, sometimes I expect it could be even better, because the problem in the midline is the regaining of the muscle direction, because especially in wider cleft, the space between the oral nasal layer is bigger, so it's a bigger space, and then the muscle go back, and this area usually fibrose and pull the muscle again. But when you are using this deflastic plate, you are avoiding this, but also you will have the same problem. But wider cleft furlough is difficult also, so wider cleft will be difficult in both situations. But yeah, it's both ways you can go for a good result if it's done properly.
Okay, thank you very much.
Thank you.
Thank you, Professor Honda. And next, we actually have a very special guest here with us today, Professor Seward. So I'd like to invite Professor Seward for a few comments.
Well, thank you. Yeah, thanks for your talk. I really enjoyed it. I think we have fairly similar philosophies on VPI management. Just to the point of the furlough that we were just discussing, when I started doing palate re-repairs, I'd come over from England. I'd trained kind of in the Summerlad School of palate repair, and I was doing straight line repairs. I have changed from that to incorporate the double opposing Z-plasty. So I'll still do the muscle repair in the Summerlad style with his kind of 4 traditional stitches, end-to-end kind of bunching muscles with the, appropriate kind of release. But I've started doing, a Z-plasty on the oral and the nasal side just in front of that muscle repair. And I think it's nice to break up that longitudinal scar. I think it's nice to get that little bit of increased length. So that's something that you may consider bringing into your practice as well. I do have a couple of questions for you. So you mentioned the posterior pillar technique, which is kind of a relatively new thing that I haven't heard much about. But for many years, Summerlad has described his 4 stitches, the last of which is his cry stitch. And during the cry stitch, you're deliberately taking palatopharyngeus on each side, and you are kind of lengthening the palate, bringing those pillars together. So how does this kind of posterior pillar augmentation differ from cry stitch?
Actually, it's envelope. It's envelope lengthening, it's nothing with the muscle. So this one, actually, it's intraoperative indication. So if we have a pliable palate, so we'll go for re-repair. If we try to dissect the muscle and then we try to put the muscle in the transverse direction, and we see the envelope is not enough to put it, so then we create this envelope. This envelope is to cut between the nasal and oral side of the posterior pillar, suture the nasal side, and then put the muscle until we reach the muscle is completely transverse, and then close the nasal side. The pillar is going down, so you need to release the pillar from below. So cut it transverse and suture it as for Summerlad do it. So it's not the suture in the muscle, it's envelope creation behind to put the muscle in.
Okay. Well, that makes a lot of sense. Thank you. I've got another question just about the buccinator flaps. So, I have this love-hate relationship with buccal flaps and buccinator flaps. I like them for all the reasons you said. I think that you can create really soft, supple tissue in the palate. You can get this kind of really nice sheet of beautifully moving tissue. But I don't know if I'm the only person with this, but I have seen a decent number of kind of flap necroses, and mainly it's partial flap necrosis. But I've had a few patients that I've done buccinated flaps, and I've had really big central fistulae and real problems from it. How do you kind of protect the pedicle of the buccinator flap? Is it something that you will do with dental splints? Is it something that you'll kind of leave part of the closure open? What are your considerations when you're closing that donor site and around
I heard about this complaint from a couple of colleagues. Vaccinator, some people, I don't know. Actually, what I do, because if you see the anatomy, the buccal artery is going in the upper half of the pterygopalatine raphe, it's birthing and going under the muscle. So I like to leave the base broad as the pterygopalatine raphe. If you see in the patient, it's broad like this. and I never had any vascular problem in all the series. Maybe one partial dehiscence, but I don't know. But it's very versatile. Sometimes it looks a little bit purplish the first day, but most of them. So we try to dissect. Even we cut up to the pterygopalatine raphe if it's needed to make it relaxed. It's not under tension, and to keep the pedicle very wide. And we don't use any blocks. We leave it like this. In all ages, it never happened any problem. We're very confident about this. I know it's scary. People who used to use block, you think, no, I don't know, but it was not available, so we never used it, and it has no problem. But I think the point is to leave it as wide, very wide, and to dissect under the muscle. You take the whole muscle with you, with the flap, and that's it. And we leave a small opening, not to be tight, when we clothing the donor side.
All right. Thank you very much. Enjoyed it.
Thank you. Thank you for the question.
Thank you, Professor Seward, for your comments. And next, I'd like to invite Professor Lowe. Professor.
Hi, Dr. Ahmed. Thank you for your presentation. Yeah, from your presentation, I understand that you're using several different kind of procedure following the intravenously. In my hand, I just simply choose between furrow or pharyngeal flap. I I understand that the one should use the most comfortable procedure that you can get consistent result, and the surgeon's preference is also important. So this is just a comment. One question is that if I understand that one of your slides you show that following the dynamic repair, the speech function, the VP function could improve over time, or even up to 6 years. Am I right? You have the slide?
Yes, in this study, it was a retrospective study when this idea came to us, and I was a fellow of the grant, because we used to see the thing after re-repair, the patients appear and then they come after 2-3 years completely normal, despite we follow for a year improving, but it's not. So in this study, we retrospectively follow a group of patients. There were about 45, which we follow which we able to get the information, and yeah, there are some cases improved in 5 to 6 years, especially in younger than 6 years. Yes, older than 6 years, all of them resolved within I think 3 years, 3 years and a half. But the younger than 6 years, some cases reach up to 6 years. And this is expected in this dynamic procedure because we dissect a lot in soft. We dissect a lot in soft palate, and this scarring thing.
I don't know how much you'll understand.
It looks like the scarring is really important factor in the movement and the function of the VPF. That's regarding
this is very interesting.
Yes,
Go
please.
ahead.
No, and I know you're doing more either furlough or pharyngeal flaps, and I know many surgeons just do one technique fit all situation. But how much the percent of the obstructive sleep apnea and the pharyngeal flap? Because when we do it, we are very scary about the obstruction. And also, I saw some cases like I did some re-repair or fixator repair in a cases which already had pharyngeal flap. Many of them I find with time they become like very like narrow or like I think because this is like abnormal tissue put in a abnormal position. So with time, I think it have a reverse curve. Like if us the curve should be improved because the muscle will move better and the stiffness will decrease. But if you put abnormal tissue, first day it's most obstructive, and then the function should be the reverse curve. How's your experience about the curve? If you have any curves?
Well, personally, I don't do muscle repair. I do furrow when the VPI is mild, and for the moderate to severe, I do pharyngeal flap, and the incidence of obstructive sleep apnea in our series is very low. Yeah, I'll tell you a story. When I finished my training from Professor Jeffrey Marsh in St. Louis, 1995, I came back to Chang, and then I start to do a sphincter pharyngoplasty because I learned from him. Okay, so I need to try to do some cases, and I found out in when I did a sphincter pharyngoplasty, the incidence of obstructive sleep apnea actually is much higher than what my case with pharyngeal flap. So I abandoned the sphincter pharyngoplasty. But again, I mentioned that it's I think the surgeon's preference that if in your hand you do this procedure, you can get a consistent and good result. I think that's perfect, because I understand that in VPN management there are still a lot of different protocol from center, from surgeon, even in Chang, we have different surgeon. We may have different approach in our hand. But that the speech VP function could improve with time, even 3 years or up to 6 years. It's very interesting. In our protocol, if we do VP management and we follow up 6 months or 1 year later, we didn't find complete cure, then we will try to figure out to do something in addition to improve further VP closure. So maybe next time I had to wait for a longer time, see if we can expect some further improvement of the VP function. So this is good information. Thank you.
Thank you. Thank you very much.
Thank you, Professor Low, for sharing your experience with us. And next, I'd like to move on to our Q&A session. And one of the questions that Dr. Ulusanya has for you, Professor Elsherbiny, is that can one reharvest a buccal flap from the same site after a period of time? What's your experience with that?
Buccal flap? I don't think so, because it's axial flap and the vessel already was cut. So I don't think so we can do it again. It's one chance to use it.
Well, but have you had previous experience where you used the buccal flap, but then you experience a need to redo the procedure? Then what would you do in that case?
In that case, this option is already expired, and then we have to do the next, because if we do it and then first we have to see, as the protocol, we have to see where is the muscle, if it's transverse. But yes, this will be a big problem if there is a scarring and we already used the vaccinator and the muscle was there. It's a difficult problem, because at that time there is nothing to do to remove this scarring now. I don't know that if we can use other flap, but I don't have the situation. But the success rate is very good of the vaccinator flap. It's very good. But yeah, and maybe so this is the maximum what the palate can do. Then we can go for the pharyngeal, completed with the pharyngeal procedures, according to the finding.
And our next question is actually from Dr. Velez, and the question is, what about your experience with failed pharyngeal flaps?
As I told you, pharyngeal flap, very sporadic cases, very selected, and mostly it's more palliative thing, where there is no much movement, and we try to do something just to improve. So I have no much experience. Maybe Dr. Lu can give us more insight about the vision of the pharyngeal flap.
Okay, and I think Professor Fayaz has a comment. Professor?
Yes, actually, we for all our VP cases we use pharyngeal flap. I have never done even a single sphincter pharyngoplasty. But our protocol is we use 60% of the width of the posterior pharyngeal wall, and we leave 20% on both sides. And all our patients are examined by speech pathologists before surgery, and they are again examined after surgery. And we have never regretted, and the rate of obstructive sleep apnea in our patient is almost negligible. For the last probably 10 years, we had to revise two or three pharyngeal flaps. So it's very comfortable. And in our hand, pharyngeal flap surgery does not go beyond 30 minutes.
Thank you, Professor Fayaz, for your addition. Next, I'd like to actually invite Dr. Menon because I think Dr. Menon has some questions, and I'd like to invite him to ask the questions.
Yeah, thank you for inviting me. I have a couple of questions. When you have already experienced that the radical muscle dissection cause relapse, why do you again venture to redo or re-repair your palate with a radical muscle dissection without any interpositional material or so? That is my first question. And then another question is, how do you assess that the muscles are already in the exact position? You have mentioned that once the muscle is in exact position, there is no point of lengthening the palate with the buccal flap. So that is my second question.
Okay. Thanks for the questions. The first one is re-repair after re-repair. Once it happened, and if we corrected it, it's not meaning that it can happen again, because it takes time until it happens. If you if we did it like at age 4, and then the patient grow, the palate grow, there is some fibrosis which tether the muscle, and we find him at age of 8, the muscle is going back. Usually, if there is fibrosis, so we'll do the re-repair with the vaccinator, and if there is the palate is soft and pliable, which is here it will be less likely, because once there is a fibrosis, it's mostly will be vaccinator re-repair. But if the palate is pliable, the defect is mild to moderate, we can do a re-repair after re-repair. Yes, sometimes when you get the muscle back, if there is a space, a big space, sometimes we use the case I just presented. We can use the buccal fat to fill this space. If we really feel, as Dr. Samlad used to do, to suture in front of the muscle, the oral and nasal layer, to block the muscle and to decrease the space between the oral and nasal side. And also another thing which will make it less likely to happen is during the primary repair, there was a defect, and then there is a space occurred. But when you're doing re-repair, you have plenty of mucosa. You have a lot of mucosa, so you can suture the oral and nasal, and you can block it. And usually there is no much space when you're doing the re-repair after re-repair, rather than doing it in the first place, in the primary cases. The second question was, can you remind me, please?
Yeah, how do you assess, like, for example, you have said that
yes,
if the muscle is already in the right plane?
Already the right plane is a completely transverse. The right plane is completely transverse. If you look the palate and by the endoscopy from above, it's convex, in spite of concave or the V deformity, we can find it's convex or completely. And if the scope go up a little bit, you can see the dorsum of the soft palate. And during contraction, you can see the sling is completely transverse. So it's just to be transverse.
So in those cases, you are not anticipating any lengthening even with the use of buccal flap.
But if it's transverse, but you see there is fibrosis, so it's transverse during rest. But when it contract, it's tethered. So in this situation, you can use vaccinator if you see the movement is tethered by the scarring. So at this situation, the lens is okay at rest, but during contraction, still it's the scarring and it's preventing the movement of the sling. So this is why we always have to have to look and to see the difference between the movement in the nasal side and movement in the oral side. We see like big good movement in the nasal side, and then the oral side is a little bit stiffer, and the whitening of the scarring. This would suggest scope. And also you expect that this is transverse muscle, and how much is the gap? Because if it's if you because you're estimating the excursion amount of the muscle and how much if after you release the scar. If it's a big defect, so most probably it will improve, but will not resolve. So these three factors always playing to it's not always very clear like we described. There is always some gray cases, but as we mentioned that we try to be more aggressive if we are confusing between two situations.
But have you assessed your finding with any MRI studies or so?
No, I have no experience with this. It's mainly endoscopies and lateral video fluoroscopies.
Okay, thank you.
Thank you very much. Thank you.
Okay, thank you, Dr. Menon. And also, I think Dr. Fayaz has a something to add.
Yes. Whenever we repair the levator, our technique is we take the bite of the right levator, then we take the bite of the nasal mucosa very near to the uvula. We go from the right side to the left side, and then we take the bite of the left levator group. So by putting that stitch, the levator becomes fixed as far posteriorly as possible. In our cases, the levator cannot shift anteriorly because we have fixed it to the nasal mucosa very near to the uvula. So that's the point I wanted to make.
Yeah, I think it's not important. It's the more important is to avoid it's pulling from front, scarring pull from the front. So anything you can do to decrease the scarring in this area by decreasing the space between the oral and nasal side, as the blocking stitch someone like doing in front of the muscle. But suturing, because this is gradual procedure, gradual movement. If you suture the muscle to the to the nasal mucosa at that time, I don't think this will prevent the muscle to go front. It will heal within 6 months, and after 6 months it's not moving. The problem is gradual fibrosis pulling from front. If it will pull with the mucosa. Mucosa itself will be shortened with the muscle. So the point is the front in this hard post-palate junction, the anterior part of the soft palate. This is the most concerning part.
Okay, I think that concludes our Q&A session. So I'd like to hand this
Yes. Okay, thank you, Junior, and thank you, Professor Elsherbiny, for your wonderful presentation and give us a very evidence base about your previous work in the literature reviews. And I saw a lot of papers published with your great mentor, Professor John Grant. Yeah, so not only from our previous in Chang protocol, just like Professor Lowe's, we always apply a furlough pharyngeal flap or a furlough or a pharyngeal flap. So it's a new idea for us to apply the buccinator flap and the intravelar flap as well to prevent the VPI, the procedure probably in the future. So thank you, really thank you very much for your great talk. And as well, I have to thank you several our very important friends. For example, Professor Fayaz, thank you for your great comment. And you always give a lot of contribution for those patients who in need in the surrounding the Pakistan. And as well, our Professor Handa from Japan. And one of my good friend, Professor James Seward from UT Southwestern. And one of our previous good friend, Dr. Vernon, and he is a very new rising star in this clever world. So finally, I would like to invite all of our participants tonight in this webinar to show your beautiful face again. And give me a smile, and I would like to take a group photo for all of you. Thank you very much. Even now it's the nighttime or it's a daytime. And thank you for your sharing your screen. Thank you very much. Hello. Yeah, Professor Handa. Hi, James. Nice to see you, Professor Siwood. Hello, Putu. Hello, Professor Nobu. Professor Dewey and EC. I will count to 3 and please give me a smile. Yeah. And thank you always persisting to come join the ICC even now, no more COVID. And I think all of you now is very, very enthusiastic to join all the in-person meeting. But I think the online meeting always has its advantage to call all our good friends together in the specific time. So count to 3, 1, 2, cheers. Thank you for coming. And I turn to the next page. And 1, 2, cheers. Thank you very much. Thank you for all of you to come join. And do not forget the last slide of Professor Elsherbiny in this October, right? In the next October, would you like to
it's
advise
February?
again?
In February.
Yeah.
Yeah, February 2024. Yeah, we're waiting you all. Yeah.
Yes. The CLEP conference is in Egypt, so
yeah,
don't
Cairo,
forget.
Egypt.
Yeah,
waiting you
thank
all.
you very much. Sure.
Thank you.
And allow me to advertise one more, our next coming webinar in ICC. That is 2 weeks later. The Professor Charan from Chulalongkorn University Hospital in Bangkok, Thailand, and he will give us a special talk. The topic is the frontal ethmoidal encephalomenial cell, FEEM, the Chula technique. So that is a published new technique and owned by Professor Charan. So looking forward to your come join 2 weeks later. Thank you very much. And good evening and good night. See you next time. Bye-bye. Thank you all. Thank you, Professor Elsherbiny. Thank you, Nobu. Thank you, Fayyad. Thank you, Handa. Thank you, Putu. Thank you, Professor James Seawood. Bye, Seawood. Bye-bye. Thank you. Okay, have a good one. Thank you, Junior.
Thank you. We'll see you tomorrow.
See you tomorrow. Yes. Yeah, looking forward to you the big success in the Egypt the February Congress. Thank you, Ahmed. Bye.
Yeah, Professor, if you want, you can post your the advertisement for your conference on our ICC Facebook page.
Okay, great. Thank you
Sure.
very much. Thank you.
Yeah, sure. No problem.
Thank you.
Okay.
Thank you.
Bye-bye.
Bye-bye.